Okay, so welcome everybody to our learning session number 2 for our NSDPQC Substance Use Disorder Initiative. We have a really great lineup of speakers for you here today. So I'm just going to share my screen. We will jump into the agenda, and then I will introduce our first speaker. Can everybody see my screen okay?
Okay. Yes.
Perfect, thank you. So we have some really great speakers and topics to cover today. As always, if you have questions or comments, we will give time at the end of this each talk for you to ask any questions, or we can have like kind of a short discussion. We've got some time kind of buffered into our schedule for some interaction. So don't be afraid. If you have a question or comment, put it in the chat. I'll be watching that, or to come off and like unmute yourself and talk. But first speaker we have, I'm going to stop sharing really quick while I introduce our first speaker, Mariah. Mariah Sir was born and raised in Rapid City, South Dakota on May 12th, 2019, which is my birthday. So celebration day. She decided she was no longer going to allow addiction to control her after being an opiate and meth addict for 10 years. She was hired as a part-time peer support at Project Recovery and quickly became the lead peer support specialist in charge of training and supervision. She serves as a guide and a mentor to help those who are wanting to get sober, and Mariah has completed certifications for peer support specialist, motivational interviewing, and CPR. She works hard to lead by example and embodies the values of non-judgment, honesty, and harm reduction. She's a mother of a teenage son and made an appearance on Dr. Phil, which I do plan to ask you about later. And she is extremely dedicated to her work. Her past did not and does not determine her future, and she strives every day to use her mistakes as opportunities to learn and grow. So Mariah, I will turn the time over. Oh, let me hurry. We just had a few people join in the waiting room, so I want to make sure they're joined before you get started. And then if you want to share your screen, you are welcome to if you have anything, or if you just want to talk, that is wonderful too.
Absolutely. We are going to wing it today. So I just want to say thank you for allowing me to speak today. And what I'm going to kind of talk about today is just my life, my struggles, my successes in life. So I am 4.5 years sober, which has been a journey in its own, but an amazing journey. So we'll kind of start from the beginning. I have lived in South Dakota, Rapid City, South Dakota, my whole life. I'm born and raised. Sorry, are we good? Okay. Born and raised in Rapid City. My childhood was one where I had a large, loving family. But having a large family, unfortunately, there was some who took some innocence away from me. And that carried into my adolescence. And in my adolescence, a very trusted youth pastor continued to take my innocence away. I carried this into my teenage years, and I would occasionally use recreational drugs, drinking, marijuana. I didn't really know about substance use, of course, because I'm a teenager. I thought I knew it all. I ended up getting pregnant with my beautiful son, Hayden, at 16, and I ended up having him 2 days after I turned 17. During my pregnancy with Hayden, I stayed away from any substances. What led into my long-term substance use was when I turned 18. I was living by myself with my son, and I had to have a minor surgery on my knee. And this led to months and months of prescribed opioid medication. I took it as prescribed. after months of being on it, I told the provider, I don't believe I need to be on this anymore. I think I'm fine. They took me off, and that's when I discovered what withdrawals were. Because of those withdrawals, I ended up making decisions into getting stuff off the streets. And this led to a road of using opioids to meth, and it turned into a 10-year sentence for me. During those years, I've lost a lot. I've gained a lot. I became a felon. I went to jail. I've lost really close people to me. What led me to my recovery was ultimately seeing my child suffer because of his mother's choices. I'm sorry, today's been it also took for me to do something to my family that you can't just take back. And on May 12th, I woke up that day going through withdrawals, sicker than you can ever imagine. And I decided that I was no longer going to allow substance use to control my life. That was the hardest but best day of my life ever. 8 months after being in recovery, well, let me just step a little bit back. When I decided to get sober, I came to Project Recovery as a patient, and they started me on Suboxone for my opioid use disorder. That has been a saving grace in its own, and I'm still on Suboxone till this day. I am just now on Sublocade. But 8 months after coming into the clinic, being sober, I became a part-time peer support specialist. So I help those who are struggling, sharing my story, getting their story, being able to just help them with anything, just to relate to them. I then became the lead peer support specialist, and then I became the assistant manager. And now what I'm doing is we have a new program where I am working with individuals who are high utilizers of the hospital. Majority of them do have substance use, but I'm able to be with them on a more personal level of being able to go to their homes, or if they're homeless, being able to go where they're at, getting them into treatment. We've gotten so many people into inpatient treatment, and so many are doing amazing. And it has been a journey, and it's going to be something that is going to stay with me for the rest of my life. But the things I have learned and the tools I have gained have got me to where I'm at now. And I can't be more appreciative for what I've gone through and what I've learned and what I'm going to continue doing, and just being able to be part of these things. And again, I apologize. Usually I don't get emotional. So that is my story kind of summed up, and I appreciate you guys.
Thank you so much, Maya. I seriously had chills and like tearing up during your story. So thank you for like opening yourself up and being vulnerable and sharing that with us. Just do you have any maybe advice or anything for our physicians and nursing staff that are here, for anything that they could use in their practice, anything that was really helpful or meaningful to you?
Absolutely. There was numerous times that I seeked out help by going to the ER, by going to local services. And there were several times where I was treated as a statistic, and I didn't feel like there was any, I don't want to use the word compassion, but like, sorry, you decided this, you suck it up, goodbye. And I had one provider who really listened to me and set out a path for me of options that I can do. And I will never forget her. And that made a huge difference for me, for someone seeking out to get help from medical professionals, because I hear a lot from patients now that the worrisome of the stigma. And to this day, sometimes when I being on Suboxone, I've had a pharmacist tell me, well, make sure you don't go sell your pills, because that's what, you know, whatever word she used. And it's just, it's giving that compassion and understanding that we never know what someone's going through in their day. And despite if someone's trying to get help in the moment, or they are doing good for themselves, again, it's just educating people on opioid use disorder. And that is the biggest thing that I could say, is just educating and educating and educating. And it's a beautiful thing. It's a beautiful thing to talk about, and especially the medication in itself.
That is wonderful. Thank you so much. Does anybody have any questions for Mariah while she's here? She's got patients in clinic today, so.
This is Suzanne. I have one question for you, Mariah. Like what you were saying, it really depends on how the provider is that interacts. Let's say you're working with a patient, and relapses do happen because stressors in life can bring it out. What would be the best way to approach a patient if they've had a relapse in a positive way to get them back on board? I call it getting back up in the saddle. Example I give my patients, like, you know, those crazy bronc riders, they'll ride, they fall off. What do they do? Next weekend, they're at the next rodeo. And I said, that's what you do. You just get up back in the saddle. And they kind of laugh. But what would be a way that you would find that it would make it more open for the person to say, yeah, I made a mistake, but I want to get back on track again? How should we approach that as providers?
I feel like personally, it's offering options. Options are such a big, realizing that whoever you're sitting down with, whether it's their first relapse or their 50th relapse, when someone gives someone options in their community or what someone can do, it can turn the conversation completely around. And I've seen it firsthand, taking my patients to the hospital and having someone say, you know what, you are struggling. Maybe we could try this, or have you heard of this? And it just, I see a big difference.
Thank you.
Of course.
Anybody else have any questions or comments? There's one in the chat. Thank you for putting yourself out there. You are a testament of what can be. Awesome. Okay, well, if that is it, thank you so much, Mariah. I really appreciate you giving your time and your story, sharing your story with us.
I appreciate you guys. You guys have a wonderful day. Again, thank you for letting me be vulnerable with you guys, and have a great day.
Thank you. All right, next up, we have a presentation from two doctors at Altru in Grand Forks, Ashlyn Camrith and Allison Daniel. Ashlyn was born and raised in North Dakota. She grew up on the family farm, attended NDSU for undergraduate, UND for medical school, and is at Altru Family Medicine Residency. She's board certified in family medicine, and now, along with Dr. Daniel, she's completing a 1-year fellowship in surgical obstetrics, and planning to return home and practicing a full scope family medicine with surgical obstetrics in North Dakota when she graduates. And Allison is originally from southern West Virginia. This topic has been near and dear to her heart as growing up in southern West Virginia. She has seen a lot of lives affected by substance use disorders. She went to medical school at the West Virginia School of Osteopathic Medicine and landed in North Dakota for a residency training at Altru Health System. She is now in surgical obstetrics fellowship with Dr. Camrith, and who has become her best friend, which I love that story. Once she graduates from fellowship, she plans to stay with the Altru Health System and practice a full scope family medicine in Roseau, Minnesota. Most of her free time is spent with her husband, Stephen, and 2 girls, Paige and Abby. So I don't have your slides. So if you guys want to share your screen, and come off of mute. Thank you for being here.
Thank you. Thank you for having us. Let me get this shared here real quick. Okay. Can everybody see that okay?
Yes.
Awesome. Thanks. No, there we go. Okay. All right. Thank you all so much for inviting us to present today. Like Allison mentioned, it's a topic near and dear to our hearts. So we're going to touch on intrapartum and postpartum management of our patients who are on medication-assisted therapies. So the agenda for today, so we're going to be talking about management of labor pain, postpartum and intraoperative and postoperative pain management and the differences between those things. We'll talk a little bit about discharge planning with our patients, breastfeeding and MAT, and then go through some example order sets that we've kind of come up with. Yeah. So first up, we're going to talk about management of pain in labor. So a lot of this is all based on having discussions with your patients and lots of education. First thing to remember is that epidural anesthesia is effective and appropriate in this patient population if they so desire. It's not something to be afraid of. Patients who are on medication-assisted therapies can require between 30 and 50% higher doses than their counterparts. So remembering that if they are not having adequate pain control on our usual doses, to remember to go up on our opioid medications to help them have good pain control. And like I mentioned, it's still very appropriate to use opioids for pain management during labor. Like I said, we like to start with the usual doses of opioid medications and then increase as indicated to reach an effective dose for them. And the other number one thing to remember, when patients come in for labor management, please do not discontinue their medication-assisted therapy treatments in anticipation for labor. They need that throughout. So here's an example of an example protocol that you can use if you're trying to use opioid pain medication to help a patient during labor. So recommendations are to start at around 50 micrograms. You can give it IV 1.5 to 1 microgram, or 0.5 to 1 micrograms per kilogram for the patient. And then we say wait about 5 to 10 minutes to see if they have an initial response. Then, if they have not had a good response from that initial dose, try giving 75 micrograms. And then again, wait and reassess. If you're still not getting an adequate response, give another additional 25 micrograms IV. And then that's kind of where we hit our limit. Reassess, see what else we can do to help them. If the pain returns after they've gotten that dose and they had good pain control, but then they have pain again a couple hours later, you can give that 100 micrograms dose and continue monitoring. If you're not getting adequate pain control with those higher doses of 100 micrograms, if you're needing more, that's when we really should consider consulting anesthesia to talk about regional anesthesia benefits.
Another thing to remember with those patients is that Dilaudid and fentanyl is going to be your best choices rather than morphine. They're actually going to respond better to those two fast-acting medications.
Yep. So the big takeaway today is that women on medication-assisted therapies really need to be involved in shared decision-making with their providers, and we need to have open and honest conversations regarding pain management throughout the entire pregnancy course, labor course, and in the postpartum period. It's really important when they're coming in labor, they're anxious, they're in pain, providing that reassurance that both epidurals and opioid medications are effective pain management options during labor.
Okay, and then we'll switch gears and talk about intraoperative pain management rather than intrapartum. So remember that 30 to 50%, they might need a greater medication dosage than their counterparts. If we're going to be having a C-section, regional anesthesia is still preferred over general anesthesia. Spinal and epidurals are very effective for these patients. There really shouldn't be, unless there's another indication for general anesthesia, it shouldn't be the thing that we're jumping to. Remember that we don't discontinue their MAT in anticipation of a cesarean section, and we can use those routine intra-op pain management protocols that we have still with those patients, and like we said, anticipating that they might need a greater dose than their counterparts. So as Ashlyn said, it's very important to be open and honest with our patients. So we should probably be having these conversations with them beforehand about what to expect in the operating room. This can be especially frightening for them because they're going to be scared of inadequate pain control. So let's talk to them and their support persons about the experience beforehand if we're able to. Obviously, sometimes we're not able to if scary situations arise. But definitely we should be talking to them about, the differences between sharp pains, expect to feel some pulling, tugging sensations. We don't want them to have this anticipation going in that they're not going to feel anything. So we should talk to them, about what to anticipate during those procedures. And it would be really good to talk with them beforehand too about breathing techniques, coping strategies, things to assist with that procedure if those pulling sensations do become overwhelming for them.
Talking about intraoperative pain management too, if it's possible, if it's a scheduled repeat C-section or primary C-section, something that is controlled and scheduled, meeting with our anesthesia team beforehand too to really talk about those options and kind of go through things, just having more people on that treatment team and helping the patient feel empowered with what they're about to go through. Then we're going to switch gears and talk about postpartum pain management. Again, remember to continue MAT in the postpartum period. And then after that, just like patients that are not on MAT, using routine pain management strategies, like just continue the same old. Remember, NSAID still work, acetaminophen still works, routine peri-cares, those are super important. At Ultra, we're lucky to have occupational therapy that helps us with postnatal ultrasounds too. All of the things that work for patients not on MAT, again, we still want our patients on MAT to use those services as well. And remember that sometimes opioids are indicated and safe to use. So if a vaginal birth was especially traumatic and otherwise would require those opioids, please do not be afraid in this acute instance to treat with opioid pain management during the intrapartum or hospital stay. And then, so if we do are in need of prescribing those medications, we like to start low and titrate up. So if you're prescribing the opioids, sometimes patients can benefit from the same dose, but they might need that 30 to 50% increased dose as you go. So assessing for effectiveness is really important. And if we're not achieving adequate pain control on those standard initial doses, going low and slow to help them get that pain under better control is important. Example would be using 5 milligrams of oxycodone and titrating up to 10 rather than just assuming that they might need more and giving more initially. And then again, don't forget about the other routine medications like Tylenol and NSAID therapies.
And I think like Dr. Camrat said, it really is important that we not be afraid to treat their pain. They're still human beings. They're going to have that hyperanalgesic response. We need to be, responsible and taking good control of their pain for sure. Yeah. So post-operative pain management, it's kind of the same little spiel we've just been giving.
Yep.
So obviously you're going to continue that MAT and you're going to continue on the same dose that they were coming in on. You're going to use the routine post-operative pain management as well. So either IV or PO, Tylenol, NSAIDs, the non-pharmacologic pain management strategies, ice packs, things like that. And definitely make sure that we schedule a bowel regimen with our patients also post-operatively. So start with the usual dose for patients that are not on MAT. So typically we start 5 to 10 milligrams of oxycodone, and then titrate up, remembering that they might need that 30 to 50% increase. And that's that. So yeah, so like we said in this case, start with the slowest dose that's standard at your institution, and then titrate up based on the patient's pain. And then consider scheduling both opioid and the non-opioid medications initially to maintain that adequate pain control. I see something that we see in the hospital. It's much better to get ahead of that pain rather than trying to catch up. Like I said, they're going to have that higher pain response. So it's better to be on top of that pain rather than trying to catch up later after they're in excruciating amount of pain.
So then we'll switch to discharge planning. Again, women who are on MAT, please continue the treatment intrapartum and then as they discharge as well. MAT is usually continued sometimes indefinitely, and the postpartum period can be extremely stressful. That's a significant life change, lots of psychosocial stressors, physical stress, sleep deprivation. We've done call shifts and we can be loopy afterwards, and this is even leaps and bounds beyond that. So really having that stability with their medication treatment is really important during this time. If, like I said, it's a high risk. So if there's a chance that the patient would want to be discontinuing their MAT treatment during this period, really keep a close eye on them, and it's something that we don't actually recommend at this time. So things to remember prior to discharge, patient comes in, delivers. As soon as you can afterwards, especially during working business hours, getting in contact with the patient's outpatient MAT provider to help confirm what their treatment plan was and what they had talked about, and kind of come up with for a general plan after discharge, just so we're all on the same page. And then making sure that we schedule a follow-up visit with their MAT provider outpatient as soon as possible after discharge. So then at discharge, we already have all that figured out and done so that we feel comfortable discharging them home. But we want to make sure that the patient has enough of that medication to last until their follow-up appointment. If there's any delay in reestablishing care, we want to make sure that we provide a prescription for them for that time frame to get them to their outpatient follow-up. Because accidental, just not having enough medication at home, not having that plan, that can lead to accidental times without the medication and then potentially a relapse. So this was something that was prior, maybe a little bit of a gray zone, was that since it is a discharge medication, it has to be a prescriber with the DEA waiver is only allowed to prescribe it. But now there's been a new update. So the MAT Act was passed, which allows the need for the DEA waiver. So any prescriber with a Schedule III authority can now prescribe buprenorphine for opioid use disorder in their practice. So then any providers, I know at least it's all true with our residents, we are allowed under supervision to prescribe MAT therapy. So we can help with that prescribing until the patient can be seen outpatient.
Yeah, and then we'll talk about breastfeeding and MAT. So MAT is not a disqualifying factor for breastfeeding. In fact, it really should be promoted. It's going to promote skin-to-skin contact with that baby, suckling for pain control and comfort, and just overall bonding. So newborns are held frequently. They're kept in that low stimulus environment. They're going to have frequent opportunities to feed and suckle. All of those things are actually going to lower the incidence rate. And if they do have NAS, the neonatal abstinence syndrome, they're actually going to have less severe cases. So we absolutely recommend that even if patients are on MAT, that they continue to breastfeed in the postpartum period. It's important to provide education regarding lactation in the inpatient and outpatient settings. We're very lucky at our institution. We have a great breastfeeding team. We have inpatient consults and we have outpatient lactation clinics as well. And so provide that education with your patients that are on MAT or just not even on MAT. All patients can provide that, give that support and give that information. We want to encourage rooming in with the newborn. So then, we have that low stimulus environment and frequent feeds for the baby. And just again, reiterating, breastfeeding, it decreases the incidence and severity of NAS. So definitely recommended.
So now we're going to switch gears and talk about some order set ideas, some little changes that we can make in our daily life to kind of help us be prepared when our patients who are on MAT come in. So first off, we'll talk about some nursing interventions. At All True here, we're really lucky to have the EPIC system, so we can even go through some nursing communication orders, and it work really well with our team on those interventions. So something to recommend and consider would be having, once we give that opioid pain medication during labor, have them be on bed rest for about 15 minutes, and give that pain medication. We just want to assess that response, have providers or nurses at the bedside, have a continuous pulse ox on. We just want to see how they tolerate it, and then continue to assess that pain scale for that 10-minute time span after giving the IV medication. And then it'd be really important to if the nurse at the bedside is doing this and assessing, if they notice that one, it's not adequate pain control, to let the provider know right away. Or if it is, we don't want to just assume that we're just giving more and more. We also want to, again, communication is key with this. And then examples for medications. Again, assess the situation, but if opioid pain medication is needed, you can try the IV fentanyl 25 micrograms once for that severe pain. And then we would just put in the caveat that would be used in the order set part, would be reassessing for their pain response after about 10 minutes and contacting the provider if it's not achieved, and then the pain hasn't decreased by an appropriate amount, like 2-ish points on the pain scale, to assess the need for more medication. Because again, 30 to 50% increased doses are needed by some patients. And then some other miscellaneous order set ideas would be having, when the patient comes in and they are admitted to the labor floor, having that social work consult also available, getting our lovely social work team on board earlier, so that we can all work together. Even to work on discharge planning, starting early is always more helpful. And if there's any concern, again, this is more provider suspicion based, but if you would have concerns that the patient isn't taking the medication like they're supposed to, or just not acting appropriately, and you feel that UDS is needed or you're in drug screen, if we're looking for buprenorphine or the substances specifically, we want to use the med scan UDS. So then postpartum or post-operative order set options to add in, having a heading for our medication-assisted therapy patients right there, just to continue that home medication. It's almost like a little flag or alert to be like, don't forget, make sure that they have their usual standard dose that they've been on continued. Sometimes we just forget to hit a box, or it kind of gets overlooked, and then all of a sudden your patient doesn't have their needed medications. And then again, that inpatient consult to social work to help us out too. And then for discharge order set options, making sure that we get the follow-up scheduled with their MAT provider. The sooner the better, that 1 to 3 day period. But again, and over the weekends, it can be hard. So if it's stretched out a little bit, and then just making sure that they have medication available until that follow-up. And then an ambulatory referral to lactation in our breastfeeding clinic, if that's something that they're interested or desire. And then discharge medications, again, continuing that home medication or that pregnancy dose until they can get to see their follow-up provider. Those are some of our references. Any questions?
We have a copy of your PowerPoint slide. This is excellent. I'd like to present it at my healthcare facilities.
Oh, yeah, thank you. Yes, we had some trouble uploading it, so we'll get that to Morgan and get that passed out.
Thanks.
Thank you so much. That makes us feel great.
Thank you. we can't take all the credit alone too. Our family medicine providers here, we've got a clinic that we are starting with buprenorphine and substance use, and so a lot of this has been under direction of our attendings and our clinical pharmacist, so they really helped us a lot with this. So, yeah.
Any other questions before we let these ladies go? Oh, we have one in the chat. If a patient is on Suboxone, admit to NICU or NBN. I don't know if you guys can see the chat.
So I think that's kind of actually, yeah, we see it now.
Yeah.
Okay.
So that's actually kind of, I think, institution dependent. So here at All True, somebody that's on MAT, the newborn doesn't necessarily have to go to the NICU. We have a special care nursery, and so we're just kind of like aware that, it's not the regular newborn nursery, but we just have that in the back of our minds that we might be seeing NAS. There is a higher risk that they might have to go to the NICU depending on how the newborn is doing. But here at our institution, we don't necessarily send all of our babies that are on NAT straight to the NICU. It just kind of depends on how they do afterwards. But that's another one of those things that we really need to be talking to our patients about.
Yes.
Baby might have to go to the NICU. We want to do that sleep, eat, console kind of thing to keep them at risk of not going.
And then do you do any different vital signs than your routine newborn nursery care for those, and just do the
Yeah,
eat,
For
sleep,
the
console?
newborn.
Yeah, because it is special care, and I don't have that policy. We have some policies in work for that too, but because it's special care, we actually have a NICU nurse taking care of them on the rooming in with the moms, and they work alongside our postpartum nursing staff to keep a closer eye on them.
Okay, that's what we do here too. So thank you.
Awesome. Yeah, absolutely.
And it looks like someone put in the chat too that they're specifically going to be addressing that during their talk. So
Yeah,
that'll be
perfect.
excellent to follow
Yeah.
that up too.
Wonderful. Well, if there's nothing else, thank you, ladies, so much for giving us your time. And don't forget to check your email for what I sent you yesterday for both of you, and then we can get that going for you guys.
Thank you.
But
Thank you so much for the opportunity.
Yeah, thank you so
Appreciate
much
it.
for having us.
Yeah.
Okay, so for our next speaker, we have Kelsey Buss. She is a licensed master social worker and is currently a child protection services field service specialist with the Children and Family Services and Health and Human Services of North Dakota. She has been in this position for approximately 1 year, and prior to that was a CPS social worker since 2019. Kelsey has been working in child welfare in North Dakota since 2016 and has always had a passion in working with children and families. So this next, I probably should have said this before I introduced Kelsey, but we have a representative from North Dakota and South Dakota to kind of give us some legislative reviews and updates on some of the things that have been happening with both of our states. And so we have Kelsey, and then I will introduce Valerie after Kelsey is done. But we will, yeah, so I will turn the time over to Kelsey.
Yeah, thank you. So like Morgan said, we had some legislative changes that went into effect August 1st. So about a month now that it's been in place. And specific to substance use, we work with substance exposed so this is where a policy or a legislative change came into play. Previously, they were identified as substance exposed newborns. And they were identified as newborns were up to 28 days old when we could work with them under the substance exposed newborn terminology. That is now changed to substance exposed infants, which is any child up to 12 months of age could be identified as a substance exposed infant. This came about, and many states across the United States practice that same with that infant being up to 12 months identified as substance exposed. And so this may, if we're seeing individuals or that moms are identifying substance exposure or alcohol misuse during pregnancy with that child, that would be now reportable and potentially opening for a child protection assessment. The other kind of language changes came about with alcohol misuse, meaning drinking that results in a harm to one's health, interpersonal relationships, or ability to work, as well as substance use disorder. We added that to our law for child abuse and neglect. And so really, I guess, regarding that, it just opens up to physicians and hospital staff to report if there is that knowledge or suspicion of use during pregnancy for that infant. It's a very brief, I didn't have a PowerPoint or anything like that. The individual that was going to present ended up with a family emergency. So
yeah, you got handed this very last minute. So thank you for just being willing to come and talk to us. Does MAT require postnatal drug testing as a substance exposed infant? That's in the chat.
Okay, so does I guess I don't know for certain. I don't know. That would, I guess, maybe be a hospital policy. We do see some that are tested and that, I mean, sometimes it's sent to us, and if it's sent to us and it's identified that this, you know, mom was using or she was completing MAT and there was no concerns for other drug use during drug or alcohol misuse during pregnancy, it would just be screened out on our end. We can offer assistance as far as working with the family for an alternative response, just to provide some additional support if they're in need of that, but it wouldn't be, we wouldn't be required to work with them. Does that answer the question? Is there any update about marijuana maternal exposure? It is still identified as, it would, I mean, it would still be a substance exposure, including any, it's any law or unlaw, what is it? I want to quote the what it indicates, and that would be in yes, it is still reportable, I think. I'm trying to find exactly what it indicates. So it's any controlled substance, including any amount of marijuana, is still listed in our law. Is that even if they have a card for medical purposes? Yes, because it is not identified by the CDC to be lawfully prescribed. So it would still be reportable at that time. I know marijuana is a hot topic, and even just in with workers and things like that. So,
all right. Any other questions? Anybody want to come off of mute so we can? Okay, awesome. Thank you so much, Kelsey. I really appreciate you, especially having this thrown at you 2 days ago.
No, that is just fine. I appreciate it.
So yeah. Thank you.
And
if
there's any other questions, feel free. You can reach out to myself or Kirsten, and we would be happy to answer any additional questions.
Would you like to drop your email in the chat? And then that way, if anybody has questions, they can follow up or expand on any of these questions that were brought up today.
Yeah.
Awesome. Thank you. And then now we have Valerie Kelly. She obtained her MA of Business Service Management from Black Hills State University. She joined the Department of Social Services in 2005 as the constituent liaison. In 2016, Valerie joined the Division of Medicaid Services as a program specialist, and she recently became the program manager for the new South Dakota Medicaid pregnancy program.
Thank you.
So thank you for being here today.
Yes. Thank you for having me. I do have a PowerPoint, so I'm going to pop that up right now here. Hopefully, if I can do this right. I'm usually in Teams, so
we're throwing you off a little bit.
I know. So I may have to ask for guidance here on how I share my screen.
So at the bottom, there should be a green button right in the middle for share screen.
There it is. And we got it. And here we go. Maybe. All right.
Yep, it is. Yep, we can see you.
Okay, cool. But I don't want this view here. It's hiding my. Okay, sorry about that.
No,
I had to move that to the bottom. Fine. I couldn't find my share. I couldn't get to my share. Okay, we did have some changes this past legislative year. A few things transpired. We, effective July 1, of this year, Medicaid eligible pregnant women now have full coverage Medicaid for a full, I guess I'll continue on in the next one, but the unborn children coverage, which is the CHIP program, there is no changes to that. So currently that program still remains only covered while the mother is pregnant, and we can only receive any billing for a postpartum exam if it's been billed on the global, because their coverage does end the day after that they give birth. Postpartum coverage, also as of July 1, Medicaid eligible postpartum women will have full coverage, do have full coverage Medicaid. Also,
Valerie, I'm so sorry. We still see the first slide.
oh, really?
We don't see your presentation view. No, unless it has changed. It's like just frozen on my screen.
Oh, okay. Well, what do you see now?
It is the same. Is it just my screen, or is anybody else seeing?
No, it's Doc Morgan on the.
Okay.
I wonder why it's
maybe hit stop share and try share again, and maybe that might.
I'm gonna try something here.
Take it up
because I have my laptop and I have it on a different screen. So, and okay, unshare or stop share, and we'll try this again.
No worries, we're good.
Goodness.
I feel like this is kind of what we get for Zoom meetings and all of the technology is there's always little hiccups.
Okay, so what do you see right now?
It is still that same view with like the thumbnails on the side.
That is, oh, okay, just a second here.
I wonder if you go to the bottom right, there's the little presentation right by like the zoom in and out on the PowerPoint.
So sorry.
No,
I
you're
know
totally
I'm on my
fine.
PowerPoint. Screen, camera, and show. No, don't want to do that. I just did something bad.
Okay, it changed. So I see right so go to display settings at the very top and put switch presenter view and slideshow. And then I think we should be able to see the slideshow. Yep, now we see the slideshow.
Oh, cool. Okay. So okay. All right. Well, here we go. Well, thank you.
Yeah. Teamwork.
Teamwork. Okay. So now you're still seeing, I switched to the next slide. We're good, right? Okay, perfect. And I think it's because I have my laptop hooked up to a separate monitor. Okay.
No worries.
So I'll just, postpartum coverage as of July 1, Medicaid eligible pregnant women have full coverage during their postpartum period. And they are now eligible for 12 months of care during that postpartum period. Now, the bigger thing that I think is really exciting and is my new role. We also with Session came through a vision to create a pregnancy program, which is overall going to provide more wraparound services. The purpose of the pregnancy program is to increase timeliness and utilization of prenatal, postpartum, and well-child visits, connect pregnant and postpartum women with supports, and improve health outcomes for both mom and baby. In order to develop this program, we've created a stakeholder work group from a variety of our healthcare systems, IHS, Tribal 638s, FQHCs, and other clinics. So we just wanted a big scope of providers as well as administrative staff in order to create this particular program. The purpose of the stakeholder group is to advise the Department of Social Services on policies and procedures related to the creation of the pregnancy program for Medicaid recipients, which will include from them lived experience feedback about proposed policies, support for program implementation, recruitment of additional providers, as well as ongoing innovation. Another component of developing this program is we have contracted with the University of South Dakota to do a survey of current Medicaid recipients and those who have been pregnant within the last 2 years and were on Medicaid. From there we will, be reviewing and analyzing those particular results. We will also be doing 4 focus groups, and the locations of those focus groups are going to be Sioux Falls, Pine Ridge, Mobridge, and Rapid City. Currently, the proposed provider qualifications are: the provider must be a licensed physician, physician assistant, certified nurse practitioner, certified nurse midwife, working in a private clinic, a rural health clinic, federally qualified healthcare center, a tribal provider with a contract under Public Law 93-638, or an IHS clinic. They are to maintain credentials with a birthing hospital if provider intends to perform the birth or maintain a relationship and communication with another provider or facility who can perform the birth, including a process for timely transition of care. The provider must be an enrolled South Dakota Medicaid provider and have a signed agreement to participate as a pregnancy provider. Proposed provider qualifications. As a condition of participating with the program, the provider agrees to provide care in accordance with ACOG guidelines. Participation in the program does not obligate providers to provide services that are not covered or not authorized by South Dakota Medicaid. The initial visit should be scheduled prior to 12 weeks gestation or within 2 weeks of the patient contacting the pregnancy program provider if the patient has passed the 12-week gestation. Included in the requirements are your routine prenatal care requirements, screening and referral requirements, care coordination requirements, collaboration requirements, access to care requirements, and quality improvement initiatives. So as I said, as of right now, we are in the development phase. We are having meetings right now with our stakeholder group once a month. Our hope is to roll out this program early in 2024. Does anybody have any questions at this time?
You can come off of mute if you want to, or drop it in the chat. This Pregnancy Help Home is a really exciting thing happening in South Dakota that as a PQC, we've been able to kind of be a part of a little bit.
Yes, and I'm very excited because I'm glad that we also have our sister state here, I'd like to say, because we do have providers that are right there on the border that will be serving some of these particular recipients and may then also wish to enroll. If they're in the primary care provider program as serve as a PCP, then they too could, if they're interested, also enroll as a pregnancy program provider.
Wonderful. Anybody have any questions? Or did she just answer all of our questions? All right.
Right.
Thank you
Well,
so
thank
much,
you so
Valerie. I
much.
appreciate your time.
Yes, thank you.
All right, next up, let me get my stuff organized and our next slide going. Okay, we are going to hear from Dr. Thurtle. So she is a pediatric hospitalist and the chair of pediatrics for Sanford Bismarck. She is also the medical director of quality and patient safety officer for the hospital. She has a special interest in quality improvement and is a Six Sigma Black Belt certified, which is incredible that there's so much work you have to do to get that. When not working to improve care for children of Western North Dakota, she enjoys running, reading, and spending time with her husband and 5- and 3-year-old boys. Dr. Thurtle, I will let you come off of mute. And if you want me to run the slides, I can, or if you want me to stop sharing, I can let you share from your screen. Hold on. Hey, oh, you're muted. Oh, yes, you can call in for audio if you need to. Oh, that is so strange. The browser can't access your microphone. Yeah, if you want to use your phone and just dial in, I can add you to the meeting and then is it selected on the right microphone? Like on your Zoom, if you go to the microphone, there's like a little drop down right next to it that you can select what microphone. Thank you everybody for your patience. Oh, no worries. We will figure this out.
Oh, there it goes. Can you hear me now?
Oh, yes, we can hear you. Wonderful.
I don't know why it just all of a sudden asked if it could access my microphone. So, okay.
Well, it always just knows right when we don't need it to do that.
And I'll go ahead and share if that's okay. I added a slide.
Oh, fantastic. I will stop sharing then.
Thank you.
If you would like to send me those updated slides and then I can get it updated in our slide deck before we share it with everybody later on with.
You can just use that one.
Okay.
All right. Can you see the slides?
Yep, we can see it.
All right. I think I have the wrong ones. Let's see. Can you see the second slide?
No, this is still sharing just the yeah, go to the middle one and we should be able to see it.
That one?
Yes. Oh, that's so strange. It's doing the same thing that it did to Valerie. I still see the thumbnails and like in the regular view, not the presentation view.
Let me do one more thing. Okay. Share. I really need to get the app on here because like I'll just share the whole screen. Mm-hmm. It's like going very slow.
All right, there we go. We can see the presentation view.
Okay, perfect. All right, so I'm going to talk about, we are doing prenatal visits for mothers with opioid use disorder on the pediatric side. So just to give you a little bit of context about where this came from. There we go. This is part of a larger quality improvement project that we are working on to improve care for infants with neonatal opioid withdrawal syndrome, or NOWS, which is now the preferred term, of course. It's only loading half of this slide. That's really helpful. But as you can see, this is actually part of the third wave of interventions. So we've already successfully decreased our length of stay by about 6 days. We've also decreased direct costs for each patient by about $6,000 per patient. And we've increased our rates of infants receiving any breast milk in this population. So the third, what we found kind of going through these is that our troublesome patients, or the infants that still have pretty severe withdrawal, as is well described in literature, are the infants with polysubstance use. And I don't necessarily mean like street drug polysubstance use, more like there are numerous substances that mom is prescribed that have abstinence syndromes associated with them. So the most common co-occurring abstinence syndromes are SSRIs and tobacco or nicotine, withdrawal syndromes. Those infants are having a much harder time. So we just was wondering if maybe some more careful prenatal planning, but then also kind of just educating caregivers on what to expect and the importance of their presence because the first two interventions were really driven at eat, sleep, console. So just really outlining how important the caregiver is, what their role is in NOWS for their infant, and how important they are in preventing severe withdrawal. So that's kind of what led to the entire visit. So the objectives for the visit, I guess the primary objective, it's really that I feel very strongly that all mothers deserve to have a joyous and safe experience in the hospital and the newborn nursery with their infant. So really laying the groundwork for how can we make this as stress-free for both the care team and the caregivers as possible. Specifically for this visit, my objectives are to obtain pertinent medical, family, and social history that may complicate or positively contribute to NOW's newborn course. Again, we highlight the importance of family presence, holding, rocking, environmental factors that decrease the incidence of withdrawal. And we identify maybe other caregivers that can come hold the baby. We talk about people from church or other kind of positive, supportive influences in these patients' lives and encourage them to bring them into the hospital. We educate families on neonatal opioid withdrawal syndrome, the expected hospital course and interventions, including the eat, sleep, console methodology, and what the indications for pharmacotherapy would be. I have found that these families are really, really anxious when it comes to the possibility of their child getting oral morphine for withdrawal. So we really just lay out very clearly what that would look like and talk through that whole process, and they're much more comfortable with it after the visit. We also discuss the importance of breastfeeding and any contraindications or barriers that might exist. We look at the medications in their entirety. I don't have a formal like CLC certification, but I do a lot of breastfeeding medicine, hoping to sit for my breastfeeding medicine boards. So I take a good history for breastfeeding, and we kind of discuss any barriers that might be there and make a plan for that going forward. So it's been really powerful to help empower women to breastfeed too. I create a written care plan that is a progress note that will be available for the team that is taking care of the infant at delivery. And it really just highlights all the complicating factors. We've had a few infants with extremely prolonged length of stays that I don't wonder if we aren't trying to treat SSRI or another kind of co-NAS, if we got that confused for now. So it's just kind of highlighting the curbs and gutters around this particular infant and what their care might be. So everybody's really well informed taking care of that specific mother-infant dyad. And then we do discuss the state and federal requirements for drug testing and the role of social work. We have previously been told by Burleigh County that and this has kind of been the dogma in the pediatric world nationwide, that CAPTA requirements do require testing and plans of safe care for these infants. So I'm going to take that information that we just learned back to my team and see how we can change this. That'll be a really positive kind of development for these families, because this is a big hang up for them too. And it's something that I feel taints the hospitalization a little bit when we do get social work involved and they're not aware of it ahead of time. So it also allows us to solicit and address any questions or concerns from the parents or caretakers. They're really curious about what are visiting hours. A huge misconception that these mothers are going to have their infants taken away from them, and just reinforcing that, no, we actually want you to stay in the room. What can we do to get your other children cared for? What services do you need that allow you to room in? So that's really helpful to empower these families. It's really rewarding. Just some of the nuts and bolts, the logistics. So we schedule them at the same time as an MFM or OB visit. A lot of these women, especially when you work in Bismarck and they see MFM, they come from very far away. So I don't make them make an extra trip for this. I do tag it on to another OB visit. We try to do it in the last trimester, but 30 to 34 weeks is ideal. You don't want to do it too late because there is some planning involved in being in the hospital for that 4 to 7 day stretch. So I like to give them time to plan around that. The whole visit takes anywhere from 20 to 60 minutes. I'd say 40 is about normal for face-to-face time with the patient. Okay, I currently don't bill or place a professional charge at all. I am utilizing the encounter from the OB and I just place an extra note. This is because Medicaid has sometimes charged these women $50 to $75 for the visit. And I really don't want it to be an extra barrier. This is really supposed to be about mowing down barriers for these women to receive care. So we don't currently bill for the visits. I told you about writing a note. So what does the visit structure look like? This is the visit form that is currently available on the AAP NAS toolkit. So the AAP has an entire neonatal abstinence syndrome toolkit that I highly recommend you guys check out. It's really awesome. That's where this form comes from. And this is essentially what the entire visit looks like. So we get just a basic medical history, current medications, and the infectious diseases that would impact care of the infant. We talk about what they're currently using for medication-assisted therapy, how long they've been on that, who's prescribing that for them. Are they currently enrolled in behavioral therapy, whatever their kind of psychological or therapeutic interventions do they have going on? Because I encourage them to keep that up as much as possible, even for the week that they're in the hospital. I always look back to see if there were any toxicology results, simply because of the Century Code that requires, if there was known use of a controlled substance for a non-medical purpose, then we do test the infant at delivery. So I just look back at any kind of relevant results, tobacco usage, or if they're on nicotine therapy. And then we look at other exposures, the marijuana, SSRIs, anything else that can cause a withdrawal syndrome. I also like to get information on things that can cause false positives on drug screening. So for instance, trazodone often screens positive as amphetamine on a drug screen. Just anything that might complicate the care of these infants, I just try to take note of. Then we get a good social history. Is the significant other involved? Have other children had prenatal exposures, and what was the mom's, what was their experience with that? It's good to know if they already have a CPS worker assigned to them, or if they have current open cases, or they don't have custody of their own children, simply because if they do have any open cases or current involvement of CPS, that precludes a plan of safe care, and they go to a different kind of bucket as far as reporting and filing of the 960. It's the same filing of 960, but they aren't eligible for a plan of safe care then. They go to the reporting kind of side of it. I have handouts from the AAP about the symptoms of NAS. We go through all that. What does it look like? I go through Eat, Sleep, Console, what all the interventions are. I let mom know, if you like to wrap, if you like to baby wear, please bring that to the hospital. We do have swings and shushers, but if you have sound machines you like or anything, I encourage them to bring all that with them to really kind of make themselves at home. Let them know that they're in charge of the care and comforting of their child. And then we do some brief discharge planning. I do look at what medication they're on, because Suboxone is 4 to 7 days, so a minimum of 96 hours, whereas methadone is 5 to 7 days, so they have to stay a minimum of 5 days. So we do make a very specific kind of care plan and what that will look like afterwards, so that the family's aware. So I also included just a little case study of what this looks like for a specific mom. This is one I just did last week. So this was a 40-year-old G5 P3L3. She was currently 31 weeks and 4 days. Her last pregnancy was in 2013. So her youngest child was 9 years old. So it had been a while since she'd carried a pregnancy to viability. And she was definitely in a very different place. So talking about that with her was really interesting, rewarding. We went over the issues that make her pregnancy more high risk. She is at advanced maternal age. She also had gestational diabetes and was starting insulin therapy at that same visit. So we were able to talk about the hypoglycemia protocol, how that's separate from NOWS, but that if the infant has kind of excessive movements or tone issues, it can exacerbate hypoglycemia. Went over the current medications. She's also on Cymbalta, a nicotine patch intermittently with cigarettes. She's doing the best she can. Prenatal vitamins, aspirin, and Miralax. And then her history with MOUD was that she started 4 years ago, and she's been on buprenorphine that entire time. She had graduated from behavioral therapy, but still participates in a support group for Recovering Women Weekly. And then she's also signed up for Tobacco Free Baby and Me and discussed the other community resources she's already tapped into. So with that information, we were able to create a care plan for her that then my hospitalist and the newborn nursery providers will use to make sure that she gets consistent messaging and care kind of across her whole entire visit with us from prenatal to discharge. So the complicating factors for now for her were nicotine use as well as SNRI use, which isn't as well described as withdrawal syndrome as SSRIs, but they definitely can have an SSRI withdrawal picture. And then we also discussed, like I said, the complicating factors of hypoglycemia, the possibility of infant needing donor breast milk or other formula and what kind of that could have on the care. Planned interventions were 4 to 7 day observation period. I also stress that range, but families really want to know like what's the minimum. So I always write minimum of 96 hours because they have to be that minimum age. We also encouraged breastfeeding. Mom was really excited about it. I just further empowered that. I reiterated that she will have lactation support the entire time that she's hospitalized with us on the pediatric unit. We created a plan for her 9 and 13-year-old. She's like, this is really helpful. I didn't really know how long I'd need someone to care for them. So she was really appreciative of that. And then I did talk about a plan of safe care for her, but I don't think she'll need one based on the information we just got. So that's really exciting if these families don't need social work and plan of safe care involvement. She's really plugged in. She has, to her county, I think she has a lot of support structures. So I'll definitely continue to screen for that. And if I feel like they're not receiving a lot of support from their community, I would probably still recommend a plan of safe care. But I think that'll be more patient specific. And then future aspirations for this project is I want to expand to all moms on chronic opioid therapy and not just MOUD. We talked about that at the MFM office really recently. We want to make a personalized plan for drug screening at delivery. So for example, our go-to for drug screening here in Sanford Bismarck is actually a cord segment. We try not to do urine drug screening on newborns because the urine drug screen is so nonspecific. We create a lot of problems, I think, with that. So for example, a mom that gets enrolled in MOUD in her second trimester, I would not want cord segment screening because that's going to catch everything that she used throughout pregnancy, right? So then for that mom, I think a urine drug screen would be appropriate. So I'd like to make more specific plans around that. I just really hate this drug screening as a gotcha for moms. There's a lot of science involved that I think is hard for social services to work through. And then I also have the option to do a telephone visit. I haven't had to yet. I've been available, but if I'm ever unavailable for a visit or if a mom's from far out of town and can't make my visit, then there's an option to do a telephone visit. So I want to give a special thanks to Dr. Gina Ariema. She is a friend and mentor. She founded the Hoot Clinic at Wake Forest University, which is a whole clinic kind of devoted to these prenatal. They also follow these babies postnatally, and she's been really helpful in getting these visits off the ground. So that is my whole presentation. Would love to take questions.
I was actually wondering if you could expound on what we were talking about earlier, how you could say you could address that if the patient is on Suboxone, if you admit NICU or NBN and just extend on that just for a couple minutes. And then if anybody has questions, please drop them in the chat, come off of mute, and we'll get it answered.
Yeah, so I think since Eat, Sleep, Console was published in 2018 by Dr. Grossman, we found out that looking at these infants, moms who are on a well-controlled MOUD, whether it's Suboxone or methadone, their likelihood for severe withdrawal is actually really, really low. So our practice is to keep them in the newborn nursery until mom is discharged. We currently do Finnegan scoring in the nursery, but that's going away in a few months as soon as my new order set is published. So the goal is we will actually no longer do Finnegan scoring at all in the nursery. It will be Eat, Sleep, Console from birth, along with normal vital signs. So it's Q4 for the first 24 hours and then Q8 thereafter. They then transfer up to the pediatrics unit where we do Q8 hour vital signs. It's written as Q8. They do Q6 to 8 hours because they kind of cluster with cares, and that's how often they do their Eat, Sleep, Console. The nurses do assessments as well, but they transfer up to the pediatrics unit, not the NICU, so that frees up our OB beds, and those rooms are large and have 2 beds, so mom and dad can stay, or mom and another caregiver. If they require high doses of frequently scheduled medication, so whenever they go into that 24 to 48 hours, Q3 hours of morphine, we do consult the NICU and often transfer, but we have only had one infant require that since we've started our Eat, Sleep, Console. So
That's awesome. Does anybody have any questions?
Thank you so much. That was a great talk, and the process also that you have told us, it looks great. So my experience since about 1.5 years being in North Dakota and Bismarck is that most of the time we see these moms who had this substance abuse disorder basically without prenatal care. And at that point of time, we are definitely, this is something new to them, that we will be testing the baby, we'll be testing her, we will most likely be observing the baby for a long time. Do you have any thought process that how that process would work, or what plans do you have in case you are seeing that? Because I think these pre-planned visits with Suboxone or methadone or some other medications, they are very few of the majority what we are seeing.
yeah, it's actually, no, you're totally right. We do have a huge population. The interesting about the population that is no prenatal care, poorly controlled opioid use disorder, is that they usually, at least in the state of, in the ones we see, and I don't know if it's the same for you, have a coexisting methamphetamine disorder, use disorder. And those infants, I've been talking to our neonatologist recently because they tend to get transferred to the NICU in the first 24 hours. And I don't wonder if that's us confusing methamphetamine withdrawal with opioid withdrawal, because we wouldn't expect the opioid withdrawal that quick. But we do know that methamphetamine, whether it's toxicity or withdrawal, I think there's some kind of talk about that in literature. But it's very quick after birth. They have very severe symptoms, but it's generally short-lived. So we're talking about maybe treating those infants that are specifically methamphetamine positive and have that really hard and fast withdrawal. Otherwise, I think all we can do is just intervene earlier. So kudos to the collaborative for trying to get more women on medication-assisted therapy. That's really the only thing that we can do for those women. But yeah, it's really hard with the moms on uncontrolled use disorders because they also can't breastfeed. So there's just a huge number of barriers to treating with Eat, Sleep, Console really effectively.
I have another question. What is your current policy regarding marijuana used and breastfeeding in the current admission?
Yeah, so that is something that when we went live with our Eat, Sleep, Console, we wrote a new policy called the substance exposed newborn that relaxed kind of our institutional stance, I'll say, on breastfeeding while using marijuana. We do leave it up to the parent unless it's clear that the parent uses a significant amount of like wax or oils and vapes that are very, very high potency. But otherwise, we kind of get a history, we go over all the risks, and we leave it more up to the parent unless there's a really strong medical indication to think that they shouldn't be breastfeeding. We've relaxed that quite a bit.
I am sorry. I just have one last question.
That's okay.
Sorry to bother you. So, one more thing, like if you have mom, like as I said, you won't always, or we won't always have mothers who would be known to us. So suppose there's a mom with Suboxone or Methadone, and she does not know that the baby would be monitored for at least like 96 hours. So if there's any resistance or any reluctance with that process, would CPS be involved after the social services, counseling, and everything failed?
Well, okay, so it's hard because a lot of these moms come in, you're concerned about drug use, there's a positive fentanyl on the urine, and you don't know, well, was that what she was gotten during labor, because you never have a chance to get urine ahead of time, and the methamphetamine's positive. And you work with UND?
I am neonatologist across the street.
Oh, you're the neonatologist across the, I'm like, I know that name. How do I, oh, nice to talk to you in person. Hello. Yeah, so our, what we've been doing, and we've gone through a few waves of this, is I think we're actually keeping those infants for 5 days, not really to monitor for withdrawals so much as to get social situations figured out, because we have found that pushing, no good comes from pushing CPS to make a plan of safe care or a determination on care for in the first 72 hours. So we've been really relaxed on moving them upstairs, but it's really more of a safe bed situation. And we find that parents often, poorly controlled substance use disorders, cannot keep it together for 5 days. And if they are someone that maybe a child would not be safe being discharged home with, because as you know, with methamphetamine especially, there's a lot of paranoia and altered sensorium that makes, I think, caring for kids really kind of terrifying. So that usually rears its head in that 5-day period. So we usually do those for 5 days, but more for a safe bed situation than a monitor for withdrawal.
That is right. So specifically, like if this is if this mom is already in a methadone program or Suboxone program, and still they disagree to have the child or the baby monitored for 5 days, what is the contingency at that time?
I have never had that be an issue. Have you had that before?
I guess you have pretty good luck then.
I have never ever had that issue before. Yeah.
Great. Thank you so much. Thank you so much.
We have a question in the chat if you would be able to share your policy on the substance exposed newborn.
Yeah, I can send that to you, Morgan, if that's okay.
Yeah, and then I will forward that on to Gina. Okay, awesome. Thank you so much, Dr. Thurtle, for your time, and happy we got questions and discussions, because that's really what these meetings are for us to come together and learn together. So if there is not any more questions for Dr. Thurtle, I will move on to our next speaker. Our next speaker is Hunter Parisian. He is a tribal health liaison with the North Dakota Health and Human Services in the Health Equity Unit. Hunter is an enrolled member of the Turtle Mountain Band of Chippewa Indians, and he has had a career in healthcare and public health for 15 plus years in federal and private sectors. Hunter has a background in health administration and healthcare health delivery systems. He has a personal goal of improving access to quality healthcare for Native Americans for current and future generations. So I am going to just stop sharing. Oh, there we go. Hunter, do you have any slides that you would like to share?
Nope, it'll just be off of my notes. I'm fairly familiar with the program, so.
Perfect, no problem. I just wanted to make sure if we needed slides being shared, we'd get that, but I will turn it over to you.
Yeah, and Morgan, if somebody, if you see a hand pop up or something, just stop me. I mean, it's super informal, so.
Okay, perfect.
I talk all day too if you just need to break it up a little bit, so.
No, hey, we like hearing you talk.
But like Morgan introduced me, I'm the tribal health liaison on the eastern side of the state for North Dakota Department of Health and Human Services. My primary area is Turtle Mountain Indian Reservation up in the northern part of North Dakota. And then I'm secondary for Spirit Lake and Sisseton Wahpeton. I work with 3 other liaisons in the state, and they also handle the other tribal nations that are within the boundaries of North Dakota. But today I'm going to talk to you about our project that we had and give you a little history of our prenatal advocate that we have in Spirit Lake. Now, a big portion of my medical experience, our healthcare experience, comes from working in the Spirit Lake Health Center on the Spirit Lake Nation. And during my time there, I dealt with a lot of enrolling patients in benefits, dealing with a lot of expected mothers, doing some managed care as well, because it's a small facility. And what we did is that we seen the patient for their first 2 trimesters, and then referred them out for their last trimester to a delivering facility to a higher level of care, whether it be Bismarck, Grand Forks, Fargo, or Devil's Lake, which is 13 miles away. But during my time of working with these expectant mothers and getting them enrolled in Medicaid into a third party, I found out that post-delivery, in a lot of cases, there wasn't a really established line of communication between the referring facility and the delivering facility. Now, it isn't a fault of one facility. It was the fault of both facilities not establishing a line of communication and then having a go-between. So what we did in Spirit Lake is we usually had a 6-week postpartum follow-up with the mother and the baby, so we can come in there, check things out, see how mom's doing, and then do her pelvic exam on the 6 weeks if it was needed. And then what we found out, we scheduled them for an hour, a 60-minute appointment, to make sure that there was enough time for mother and baby to get a thorough checkup in that first 6 weeks. But what we found out was that with EHR and then even with hard charting, paper charts, is that the information and the notes from the delivery wasn't in the medical chart or EHR when the patient came there. So what happened with that is that we now have nurses and people such as myself trying to chase down paper while the patient is sitting either in a waiting room or in a room to be examined, but the doctor who is seeing them doesn't have any notes to go off of, so they're waiting for those to come in. So a lot of the times we burnt up at the very least 30 minutes of that appointment. So now we only have 30 minutes to see that mother because there's other people in the schedule that also want to be seen. So we try to do our best, but it was always a glaring deficiency that we seen in all of our meetings that we had of, geez, what can we do? Do we have the bandwidth to figure out why this paperwork is dropping off? Why is there such a lack of communication between all the facilities? So we established a line of communication, but things happen. People move jobs. I don't work there anymore. The people who worked in the release of information departments at these larger facilities, they may have moved on to something else or retired, so you have a constant turnover of these people. So over the course of time, that line of communication that we established pretty much dissolved. So, it wasn't a continuing process once I left Spirit Lake Health Center, and then say all through. Someone didn't reach out from either side to say, this is what we've been doing, and this is what we want to do moving forward. So fast forward to my time with Department of Health and Human Services, Alicia Belay, who I worked with, was talking about some Rotary funding that was available that we had for Spirit Lake for a prenatal support group. And we went over the project. She told me what went wrong, and with a lot of programs, COVID is what happened, and people's just kind of the contact just kind of dissolved as well. So in the process of brainstorming how we can utilize those funds that Rotary awarded us, I asked her, I said, with my experience, I told her about what I just told you, is that there was a huge need for information to see if we can fund a part-time position to have somebody make sure that they follow the mother from the time that we refer her out to the time that she comes back in, and making sure that all this information is prepared and ready in the charts, ready for the medical provider, so we can maximize that 60-minute appointment that we had scheduled for the mom and baby. Henceforth came the creation of the prenatal advocate. And so we knew we didn't want to train people from the very start. We wanted to see if we can talk somebody into it who was already working in Spirit Lake's workforce, and who, felt that they had a little bit of extra time, because I think we could, at first we were able to, charge out for maybe 20 hours a week. And so it would be after their hours. But what they would do is use the existing connections that they had to establish contact with the mother before she left. And then his or her initial duty would be to make sure that these ROIs were signed and in place, giving the prenatal advocate access to the any delivery or prenatal information. I'll keep using Altru as an example for the course of presentation. That this prenatal advocate could just call up Altru's release of information department and ask, can I get so-and-so's records, anything pertaining to prenatal records from July 1st, 2023 to the delivery date of September 3rd, 2023. Can you send me all of the notes that you have in there? So she would get them either electronically or through the fax, and then we would make sure that they were scanned into the EHR and in the hard chart for when the time the patient gets there. So we always believed, back when we talked about it, that was a big contributor to us not having, us as a facility, not having great health outcomes for mom and baby, meaning, are we getting their initial screenings done, where we're missing all of these benchmarks because we were wasting so much time chasing papers. So we wanted to improve the end result and the end product that we were providing the patients. So when the prenatal advocate came along, we made sure that they had the ROIs put into place. So let me take a drink really quick. And it ended up working really well, a lot better than a lot of us anticipated it happening. So to the point where we were looking to expand. We're also looking at a doula pilot project through another source of funding, and we were going to utilize Spirit Lake as well, because there's a lady that we came in contact with through this program that is doula trained and was interested in doing the doula services as well, which we also thought would be something good to work in partnership with the prenatal advocate. What we wanted to do was set up a warm handoff to where they went to the doula, and then they started getting the information from the doula and the prenatal advocate in regards to things that they should be doing as a new parent, as in, just this past year, we had our Medicaid regulations changed, where mothers can now be covered for 12 months post-delivery rather than it used to be just 60 days. So, but one of the caveats is that the mother had to contact their caseworker and let them know that they did deliver their child, but they, to make sure that their 12 months starts from post-delivery until then. So making sure that the prenatal advocate is getting all of these messages to the mother, and then also following up informally, asking them if they have any questions, are there any needs? So the prenatal advocate could utilize networks and contacts that we've already established as tribal health liaisons, because she is part of the project that we created. and she can have access to different sources of information, the mother and child, so we can go look for the most current information in regards to what immunizations baby would need. An example, right now, the state's coming out with a lot of RSV information, so we can make sure that that new mother has these things and is aware of these things. So, like I said, down the line, improves patient, the health outcomes for the patient, for mom and child. And there was actually supposed to be her name was Jamie Tongpet. She was I handed it off to her early in the process, and it became her project. But then she recently moved on to another position, and so that's why I'm here today. And she did a lot of work on the back end and making it successful. And I wish she would have been here to let you guys know and tell you about the good news, is that even we use this small amount of Rotary funding to fund this position. One of the things that we always shoot for every one of our projects happened. We were actually able to show tangible benefits to a small project that to a certain population. And the Spirit Lake Tribe has actually taken that prenatal advocate on as a permanent position, as a permanent budget line item moving forward for the people of the Spirit Lake Nation. So we're really excited about that. And what we want to do is we want to then look back and debrief everything and look through all of our steps. And because, it's few and far between that you're as successful as this prenatal advocate was in implementation of these projects. So what we want to do is be able to package this program, and then I can be able to bring it to the people that I'm serving in Turtle Mountain, and then I can work with the other liaisons in Standing Rock, MHA Nation, and then they can possibly use the framework that we have that we already have, rather than having to reinvent the wheel. They can mold it, they can take the framework, but then mold it to what's going to work for MHA, what's going to work for Standing Rock, because every tribe within North Dakota and United States is all unique, and they're all going to have their different issues in regards to health delivery. So that's one of the things that we wanted to do, is to share the wealth and share the knowledge, because we feel it's a pretty basic service. And then we wanted to be able to just have facilities be able to just plug in a prenatal advocate who can do these things on the back end to help improve, like I said, across the board, the health outcomes for mom and baby.
Awesome. Thank you so much, Hunter. That's such exciting news that position got picked up and became a permanent position to serve the people at Spirit Lake. Does anybody have any questions for Hunter? Okay, awesome. We'll move on to our next speaker. Suzanne England is a triple boarded as a certified nurse midwife, certified family nurse practitioner, and a certified psychiatric nurse practitioner, seeing both adults and children. Since 2015, she has been the Great Plains Area of Indian Health Services maternal child health consultant, providing training and program evaluation in the areas of MCH. She maintains clinical privileges and provides care in all specialties on the Rosebud and Pine Ridge reservations. She has an adjunct nursing faculty position at Mount Marty University in Yankton. She is teaching graduate psychiatric nurse practitioner students. She received her doctorate of nursing from Arizona State University in 2011, her master's in nursing from the University of New Mexico in 1996 and in 1997, and her BSN from the University of Evansville, Indiana in 1992. She has a passion for rural healthcare. She grew up on a livestock and crop farm in Indiana, and she currently lives on a ranch in Melletteville County, South Dakota, with her husband, George, and they have a commercial Angus herd, registered Savannah and Spanish goat herds, along with a pasture poultry operation. And I want to come visit. That sounds awesome. But I have your slides, so do you want me to share my screen? Or would you prefer to share?
That would be great. And then I'll just tell you next slide and we'll go from there. I'm enjoying this talk today. I'm learning a lot of things that I want to incorporate in the practice where I work. So I'm excited.
Wonderful. I'm so glad. All right. I will mute myself and just tell me when you want your next slide.
Okay. What I'm going to talk about today is some of the activities that's been going on in the Indian Health Service from a local area level to an entire Indian Health Service wide level. And some really exciting things are happening as many of you guys are working in facilities that are oftentimes critical access, either hospitals or clinics, because most of the states of North and South Dakota are very rural. Like considering where I live, we consider it more of a frontier state. There's actually more livestock than there are humans where I live, but it's still very important to have safe OB care for our families that are having children during this time. Next slide. I wanted to introduce you guys to this. Besides just the general Indian Health Service site, we also have recently created IHS Maternal Child Health website, and there's a lot of links, especially to our national federal initiatives. So it's a quick reference referral source, and anyone can access it. You don't have to just be working in Indian Health Service. So I thought I would throw that out there for you just as some extra access as you guys are working on programs in your own facilities and practices. Next slide. And I just wanted to let you know if you ever need to contact us, the leads in the Great Plains area and for the headquarters in IHS. Of course, I'm the maternal child health lead for Indian Health Service in the Great Plains area, which is all of the states of North and South Dakota, part of Nebraska, and then we also have a tribal facility in Tama, Iowa. That's my area of responsibility. And also people that I work with on a regular basis is Tina Patera Lau. She's an OBGYN. She is the IHS headquarters maternal child health consultant. She's based out of Phoenix, Arizona, and she's also a full-time OBGYN at Phoenix Indian Medical Center in Phoenix, and she's been in practice for a long time. And Jean Howe, she's another OBGYN that I work with. She is the chief clinical consultant OBGYN. She's practiced for many decades in rural Arizona. She practiced in Chinle, and now she's currently been, I want to say for the last 12 years at Shiprock, New Mexico. And so I have a lot of interaction with them, and with some of the stuff that I'm going to be talking about today, I've worked hand in hand with them. But they welcome contact. Usually the fastest way to reach us is shoot us an email, because we'll pick it up on our cell phones. Because again, all of us practice clinically, we walk our talks. Next slide, please. And I just want to give you a general rundown. And for many of you, this will sound familiar, even providing care to non-Native American people. But the face of OB care, again, I myself live in a frontier county, is many of the people that I'm serving live in rural frontier areas and will drive many times at least an hour to 2.5 hours to reach OB appointments or specialty OB appointments. And there's a lot of miles between getting care, especially if there's an emergency. Currently throughout not just in South Dakota or North Dakota, but throughout the United States, many OB providers are retiring, or they're going into a GYN only practice. Not as many people are coming on to replace them. Also currently malpractice is extremely high, and that's why many people choose not to practice OB and just go to an OB/GYN practice many years ago. And I was so excited to listen to the family medicine residency talk. Is many family medicine providers in our smaller communities again are stopping providing OB services. Again, a lot of it's a high malpractice issue that, you upwards sometimes $50,000 or $60,000 just for the malpractice insurance just to practice in a rural area, which is very unfortunate. Many women are needing a higher level of care. Those of you on front lines of healthcare know that we have an obesity epidemic, and with obesity in childbearing women, that leads to higher rates of diabetes in pregnancy or type 2 diabetes before they become pregnant, puts women at higher risk for hypertensive disorders in pregnancy. During labor itself, it can put people at higher risk of having dystocias or other labor complications. and delivery complications for that. And with the distances that women go, especially for specialty care, if they're considered more quote unquote high risk, if they're driving, 100, 200 miles to get to care, if an emergency comes up, they're going to go to the nearest healthcare provider. And many times that's a small critical access hospital, and they're going to end up in our emergency rooms. And we want to be able to provide quality evidence-based care and keep mom and baby safe and ultimately alive too. And right now in the United States, there's a big need for emergency personnel to have evidence-based knowledge of providing care during OB medical emergencies. Many times people are specialized, and it's like, if you're in a larger facility, hey, there's an OB coming with emergency, I'm just going to call the on-call OB, the on-call midwife. But in a critical access hospital where you don't have an inpatient intrapartum unit, labor and delivery unit, who are you going to call? You're the front line, and you're going to be there triaging and stabilizing this patient, either treating their problem and or stabilizing them to ship out to a facility with a higher level of care. Many times you have to fly them out by plane or helicopter, but we want them to be on top of their game when these patients present, no matter where they present to, whether it's a rural critical access facility or it's a larger metropolitan facility. Next slide, please. And what we've come up with in the maternal child health group in Indian Health Service, it's a large group of us through all the different areas of Indian Health Service. And we're by regions, like where I work is the Great Plains region. There's Oklahoma, there's Navajo area, there's California, you get up in the Pacific Northwest. But many of us that have been in practice providing OBGYN care for many years, we're on weekly phone calls, and we have many subcommittees. And what we're coming up with, and that's what we call it, is the OB Red Book. Red for emergency, because when you see red, it's like the stop sign. You need to stop and think about what's going on. And we're in the draft phases of it now for that. And then again, when I've talked in the groups, they're more than happy. And that's what I've said earlier in our meetings with the perinatal collaboratives, is once we have the official version rolled out, I will send it to everyone, and we'll send it to every hospital in North and South Dakota. And anybody else who wants to send it on to somebody else in a different state, that is fine too. What we're coming up with, it's a quick reference for common OB emergencies that you'll encounter in the emergency rooms. And then what we're also formatting is that we're guiding to build an OB champion team of at least 2 people in each facility's emergency department, that they take this on, they participate in updates, meetings that we're going to have, so we can always be on top of our game and provide the latest and greatest in OB care to handle any emergencies that come our way. And then we're also building in a component of where we're going to have, so people have quick ready resources for simulation, so that they can do drills in the facility. Because if you're a critical access hospital that doesn't have an inpatient OB unit, you're desperately trying not to have someone come in with an OB emergency, or heaven forbid, deliver in your emergency room. But yes, it does happen. It happens commonly. It happens commonly where I work too. But we want it done safely so that there's a good outcome and ultimately a good experience for mom and baby. On to the next slide. And I just wanted to go through some of the topics that we're working on in this OB Red Book. So when it's hot off the presses and I send it to Morgan and she sends to you, she's like, hey, I remember learning about this. But the main topics, the outlay of this book is needed supplies, readiness checklist in your facility, the latest and greatest evidence-based clinical protocols. And yes, we still shamelessly from other places, like the AIMS group from California, Perinatal Collaborative, ACOG, and again, the 2 providers, Dr. Patera Lau and Dr. Howe, yes, they're members because they're fellows of ACOG for that. With education and simulation materials, where you don't have to reinvent the wheel in your facility. It'll be all there electronically to you. You can tweak it as you want to your facility on different education geared toward nurses, advanced practice providers, nurse practitioners, physicians, assistants, and then also to the emergency room doctors themselves. And then with simulation materials, like we'll give you the quick and down and dirty recipe, like for making fake blood, for doing the postpartum hemorrhage drills, things like that. We want to have everything just up front and there for you, so you don't have to go looking and digging for it versus a guideline like, well, do this drill, blah, blah. We want to give you everything you need, the materials, and then you as your own organization move forward and further develop. And then the final part goes into technical support. Is you don't have to spend all your time cruising up to date or other resources. Is that we will be responsible of sending out the updates. And originally this started out for the Indian Health Service, but over time, many of the Native American population, more and more people are moving into urban areas, just like everyone in the United States, and I think in the world, because there's greater access to resources, education, job opportunities. Also, that many of our patients, Native American patients, they're not strictly in the Indian Health Service. Mainly, most of the Indian Health Service facilities, or at least the ones in North and South Dakota, are in rural areas, is also getting the resources to other facilities that are providing care to Native American families for that. And that's where we came up in, and we've been talking about this, and we've been working on it since January. So we've got down to the draft stages, and then I'm just going to go a little more in depth in each of these topic areas of the OB Red Book. Next slide. And then for the supplies and readiness checklist, we're going to have them for OB and neonatal emergency checklist. Again, for the common emergencies that we usually encounter, say OB hemorrhage, even before delivery, abruption, postpartum hemorrhage, say premature delivery, like how to handle appropriate resuscitation for a neonate, even if you haven't taken the NOWS course, things like that. And then with the checklist for evaluation, we also came up with evaluation checklist. Is if you have this emergency event, there'll be a checklist where you can check off what went well, what needs improvement, and then you can use that in your quality programs in your facilities to take a look at changes that need to be made, say in policy protocols. You need to get a different piece of equipment. You need to have a more frequent ongoing drill, and say neonatal resuscitation, something like that. But we want to lay a good firm foundation and give you the tools that you need to have a successful program at your facility. And then also having the OB and neonatal emergency cart checklist. If you want, some places do have like the emergency carts like people have for CPR. For OB emergencies, like where I work, we have like a little fishing tool tackle box. Sometimes for the medications that need to be refrigerated in the Pyxis, we just have one that says like OB hemorrhage, OB hypertension. So we know that we get in that situation, the provider, all they have to do is call that out, say, just pull that entire box out and bring it into the room. So we have what we need as we're going through an OB emergency to stabilize the patient. Next slide. The next section is clinical protocols. We have some tools in place for OB triage in and out of hospital, and that's for our fellow colleagues that are working our ambulances, EMTs, paramedics to help them handle the situation. Of course, many times where I'm working, our ambulance will call in and they'll say, hey, we've got this going on. Can you give us some recommendations on how to proceed? And we'll talk them through it. Also, what's wonderful in the state of South Dakota, they've recently started with Avell telehealth is that the ambulance services can link in with Avell and they can help them go through a critical emergency situation and help in stabilization while they're getting them to the nearest emergency facility, which is a wonderful thing. For that, we have protocols for normal vaginal delivery. If someone hasn't delivered a baby since medical school or hasn't delivered on a regular basis, it's just things to go through, ideas for simulation of going through a vaginal delivery. Of course, what's always in the back of many people's minds is postpartum hemorrhage. I never worry about delivering the baby. The baby comes out. I always worry about what comes after the baby, which is the afterbirth, and if the mom's going to bleed heavy or not. Hypertension. This is during pregnancy, during interpartum, and also that first 4 weeks after a woman delivers, or even out to 12 weeks if somebody delivered and their blood pressure was high, is we're putting it in our facilities policies is that, and even in our template notes where you have to have a hard stop, if somebody's a female from say age 12 until like 55, is a standard question will be, have you delivered a child within the last 3 months? Because then we'll take a look at their blood pressure, because sometimes hypertensive emergencies related to that childbearing time will happen postpartum. And unfortunately, in different areas of the United States, is people have missed that. They didn't ask that question. So yeah, the person's blood pressure is mildly elevated. It's no big deal, but it was a big deal because it led to complications, is to really recognize that. And we've really been honing in on that. Also the wonderful talks we had earlier today, we have a section on substance use. Unfortunately, frequently in practice, I see many times when I see a woman for the first time, she's delivering her baby in the emergency room because she didn't feel safe if she told somebody that she was using substances to get care, that she was going to get penalized for it and possibly have jail time. And that has consequences to it too. But to talk about ways to deal with that and meet the person where they're at. Fortunately, knock on wood, I haven't seen a maternal cardiac arrest, but say if somebody comes in, they're involved in a motor vehicle accident and somebody brings them in and they're pregnant and you're coding them, like what we would do in the care we would provide to have a good outcome for the mom and the baby. Sometimes you will see people coming in extremely ill. That's what can trigger the preterm labor, is maternal sepsis, either intrapartum or postpartum. Someone comes in postpartum, and also many times too, if they don't have an OB program, especially the critical access facility, is just giving appropriate EMTALA guidance on how you properly evaluate and care for a woman who's pregnant, presenting for emergency care, especially in an OB care situation. Next slide. And then getting into education and simulation
and
materials.
Suzanne, I'm sorry, we have about 2 minutes, 3 minutes left. So
hey,
sorry.
No, we're good. I'm cruising along. For the education and simulation materials, it's just a basic OB education overview. And then we hit it hard: precept deliveries, abnormal deliveries, i.e. breech, abruption, of course, hemorrhage, hypertension, and then of course, doing appropriate resuscitation. On to the next slide. And then for technical support, we're going to do training at the IHS facilities. We're going to be doing our trial run, testing this out in my area, Rosebud and Pine Ridge. The second week of September, we're going to be doing the education courses and doing drills and simulation and getting responses from the staff to see where we can improve before I send the finalized, polished version to all of you to look at and start using. And then as we get new updates on evidence-based care, then we'll send everybody the updates and I will send them all to you. So that's OB Red Book and OB Maternal Child Health and the Indian Health Service in a nutshell. And if you guys have questions, don't hesitate to reach out to me, but I look forward to presenting this to all of you real soon.
Thank you so much for sharing. That's exciting. That I know this book has been a long process and a labor of love for you. Does anybody have any questions for Suzanne before we close up? Okay, I am going to hurry and just launch a poll real quick. It's 2 questions. If everybody here could just answer and complete the poll. It's anonymous, so we won't see what your answers are, but this feedback will help us. And as always, if you have any ideas on things that we could do better or things that you'd like to see in these meetings, please send me an email. The poll didn't give me an option to have like a dialogue box for you to just type in some answers. So please complete that. And then I just have a couple quick things I want to go over. So I'm just going to share my screen real quick. I promise I will just take 60 seconds to run over a couple of quick things, some updates for our PQC on our end. We have our annual meeting. It is coming up in October. We're going to have 2 days, 1 day full of conference. Second day is going to be interactive training. Hopefully putting in some of the stuff that we learned the first day into practice with our second day. Please fill out the form to register. We have money available to pay for some travel. We want maybe 1 to 2 per team, and we are going to try to cover as many people as we possibly can, but we are going to prioritize 1 to 2 team members per team. If you want to send more, we'll try to get as many covered as we can. And then we have purchased with our AIM funds open school licenses from IHI. We're going to have probably about 3 licenses per team available. So kind of work with your team, have in mind who you want to have those licenses for. You get access to education credits and a pretty huge variety of topics and catalogs of classes and different things you can take. So have that in mind. I'm sorry, we're running a little bit over. CDC funding, we did get our full funding for year 2, as well, along with 2 supplemental funding opportunities that we will have more information coming. Our graduate student, Ozma Huzna, had finished the North Dakota resource map. This will be available on our website, hopefully next week. I will get that up. And South Dakota, we have this resource map from the Social Services Department. And we will also link this as we work to create our PQC resource map. Thank you, everybody, for coming and being here. Sorry we ran a little bit over, but thank you to our speakers who are still here. You guys did wonderful, and have a wonderful rest of your day. Thank you all.